The presentation was made by Sanja Kolacek from Croatia. And this is the outline of the presentation. We're going to talk about some definitions and pathogenesis of intestinal failure, the clinical presentation. We're going to discuss about enteral and oral nutrition, the parenteral nutrition and its complications, the role of surgery, and the role of team approach to these children. So when we talk about chronic intestinal failure, we are talking about the reduction of the gut mass or function or both below the minimum for absorption and digestion to support life and growth. The main causes are the short bowel syndrome, up to 70%, the intractable diarrhea, mainly due to congenital enteropathies, and severe intestinal motility disorders. When we talk about short bowel syndrome, the definition is about the same, with the add that this reduction of the gut mass or function below the minimum for the absorption and digestion to support life and growth is after massive surgical resection of the small intestine. Lately, in 2017, on a society paper, a new definition was proposed from Naspagan, the gastroenterologist from Naspagan. So they define short bowel syndrome as the need for PN more than 60 days after intestinal resection, or residual bowel length of less than 25% of the expected. Now, what are the main causes of the intestinal resection and short bowel syndrome? The conditions that may lead to short bowel syndrome can start even from before birth. So we have congenital conditions like gastroschisis, so defects of the abdominal wall, the apple pea syndrome, volvulus, multiple atresia, and extensive agangliosis, not only of the large bowel, but also for the small intestine. Some conditions, most of the conditions are up to 70% will be presented during the neonatal period, with the main representative, the necrotizing enterocolitis, and also volvulus, meconium ileus may present at this age, vascular defects and accidents, and primary motility disorders as intestinal pseudo-obstruction. The condition of short bowel is less common in older children and adults, and the causes at these ages are vascular accidents, invagination, polyposis syndrome, multiple hemangioma, after trauma or due to tumor, and bypass surgery in obesity. The prevalence of short bowel syndrome and intestinal failure in children is around 10% in latest studies show from different countries. The factors that affect the presentation of short bowel syndrome are, of course, the age of the child when the resection is made. And why is that? Because as everything grows with the child, that's the same thing with the small intestine. So at birth, the length of the small intestine is 220 to 250 meters. And the length of the small intestine of the adult is up to 4 to 5 meters. So the age is a significant factor at the presentation of the short bowel syndrome. And the second part is what part of the intestine is resected. And why is that? Because the different parts of the intestine have slightly different functions and characteristics. So the jejunum has more leaky tight junctions that allows the rapid absorption of fat, water, and sodium. And the jejunum has low ability for adaptation. We're going to discuss about adaptation in later slides. The ileum is the only part where bile acids and vitamin B12 is absorbed. And this part of the intestine has a huge capacity of adaptation. If the factor of the ileocecal valve, so when we have the ileocecal valve, that protects, and we have a better prognosis. When the ileocecal valve also is resected, we have migration of bacteria to the small intestine, and we have small bowel bacterial overgrowth. And of course, if we do have the colon, the remaining colon, if we have any part of it, is a good prognostic factor, because there at the colon a small also water and electrolyte absorption is taking place, and that also helps the prognosis. And of course, the condition of the remaining intestine plays a significant role in the presentation of short bowel syndrome. Positive prognostic factors are when the ileum remains. So if the jejunum is resected, that is because the ileum has better adaptive capacity. When we have the ileocecal valve, when the colon is there, and of course when the remaining residual gut is healthy. And negative prognostic factors is when we have the jejunum left, when we have just the jejunum, just a small part of the jejunum, when the resection is done in more than in older children than 2 years of age, and when we have dysfunctional residual segment. So again, major determinants: the extent of the resection, the age of the resection, and the type and integrity of the remaining bowel. How short is still enough? When we have less than 40%, 40 centimeters, or less than 20% of the expected small bowel, so these children have poor prognosis. And this is common in children with remaining jejunum, with high jejunostomy, and these children have the worst prognosis. Life is possible when we have more than about 15 to 20 centimeters of small intestine, but with ileocecal valve there, or if we have more than 30 to 40 centimeters of small intestine, even without the ileocecal valve. If the remaining length of the small intestine is around 1 to 120 meters, after the adaptation, and together with the colon, this has a good prognosis, and these children may even win of PN. And what is intestinal adaptation? Intestinal adaptation are all these microscopic and macroscopic changes that take place after the resection. We see here that after the adaptation, the depth of the crypts, the length of the villi changes and increases. That means increased absorbed area, so a better absorption. So all these microscopic and microscopic changes are not only anatomical, but also functional. So we have this adaptation that leads to hypertrophy, so elongated villi, deeper crypts, thicker mucosa. And also functional adjustments. We see increased transport proteins on the surface of the enterocytes, more enzyme activity, and slower motility to give time for absorption. And what are the factors that affect the adaptation? First of all, luminal nutrients. You need to have nutrients. You need to have food in the intestinal lumen to initiate the adaptation process. Also, it seems that saliva, bile, and pancreatic secretions all take part and induce intestinal adaptation, blood irrigation and motility, and special trophic factors, hormones, gut hormones, like glucagon-like peptide 2, epidermal growth factor, growth hormone, and insulin. All these factors seem to mediate intestinal adaptation. So what is the clinical presentation of short bowel syndrome? We divide that in 3 phases. In the early phase, immediately after the bowel resection, weeks after the resection, the main problem is the huge watery diarrhea. So after the resection, we have huge losses of water and electrolytes. And these are more if the jejunum is resected as compared to ileum, or ileum and colon together. Then after this initial period, due to the adaptation of the short bowel and the increase of the absorption, in the next months after the resection, we have mostly nutrient adaptation, nutrient malabsorption, and increased requirements of nutrients due to their huge losses and the diminished absorption. And the late phase is the phase where we have found the bowel now is adapted. So here, if is the time where we start to decrease the parenteral nutrition and increase the enteral nutrition, is the period when we need to assess for special nutrient requirements, and it's also the period where we need to assess for the complication of the prolonged parenteral nutrition as the intestinal failure associated with the liver disease. So in the management of the short bowel syndrome, the first period, the main goal is to replace the fluid and electrolyte losses, the huge fluid and electrolyte losses. At the second period, where the children and its losses is now stabilized, we need to improve its nutrition and find this balance between parenteral and enteral nutrition, as to promote and enhance the adaptation process. And at all this time, always we need to be able to recognize and manage the complication from the short bowel itself and the parenteral nutrition. The major determinants of treatment, so as is to provide nutrition to sustain life and support growth. PN is at the first period is the main way we provide the nutrition. PN made available the survival of these children. Without PN, these children could not survive, especially with massive intestinal resection. But of course, not only parenteral nutrition, it's the combination with the enteral nutrition. We need to start enteral nutrition as soon as the children stabilize, because as we said, the enteral nutrition is the trigger for intestinal adaptation. And of course, at all this time, we have also to be alert for major complication of parenteral nutrition, as the central venous catheter-related sepsis, which may lead to loss of venous access, so we are not able anymore to give the parenteral nutrition, or the intestinal failure associated with liver disease, which is a significant factor affecting the prognosis of these children. So the role of enteral nutrition, as we said, is the promotion of intestinal adaptation, and of course the prevention of intestinal failure associated liver disease. The recommendation is to use enteral nutrition as soon as possible and to the maximum extent, but without worsening the diarrhea. So we need to be careful and avoid overfeeding. What kind of feeding? The recommendation is when we can use breast milk, then we provide breast milk. The next choice is standardized, extensively hydrolyzed formulas or amino acid-based formulas. This is sometimes depends on the diagnosis. So as an example, if we have children with gastroscopy disease, we know that even the remaining short bowel is more prone to allergies, so we would choose amino acid-based formula. Or in small young neonate, mainly we will, if we don't have the breast milk, we will use mainly amino acid-based formulas. And as the child grows older and is more stable, then we change to standard formula and then to normal formulas. And how do we give these enteral feedings? Usually we start with continuous feeds. And when when we see that, because yes, I'm going to explain later why and the differences between bolus and continuous feed. And when the children is able and can tolerate bolus feeds, then we switch to bolus feeding. So a few things about what kind of formula. As I said, all the data is from expert opinions. They're not studies comparing breast milk with amino acid or extensively hydrolyzed formula. So the recommendation is, if we can, to use breast milk. And then depending, or if we believe that the children, or the diagnosis that the cause that led to small bowel syndrome makes the children more prone to cow's milk proteinitis, then we will use amino acid formulas. And then in older children, or to older infants and children, we will switch to extensively hydrolyzed and then to polymeric diets. And of course, we will start weaning from the special formulas when the condition and the age is appropriate. As I said, a few things about the way we give the enteral nutrition. The benefits of continuous feeds is that we have better utilization of reduced surface and transport proteins, so we give more time to the bowel to absorb. The osmotic load is better tolerated this way, and of course we improve growth and intestinal adaptation. But bolus feeding is closer to the normal feeding, and also will induce hormonal surge and gallbladder emptying. Will improve the motility and the quality of life, because it's easier for the caregivers. Continuous feeds will mean that they have another pump connected, not only the parenteral nutrition part, but also for the enteral nutrition part to give the continuous feeds. So the whole family quality of life improves with bolus feeds. And of course, these we can promote the normal feeding and feeding cappings and the skills of the infant and children if we use bolus feeds. As I said, parenteral nutrition made possible the survival of these children with extremely short bowel. Firstly, we can replace the fluid losses we have at the first period and provide balanced IV intake of the nutrients. It's very crucial to save the central veins and prevent infections due to central venous catheter, and of course prevent the other major complication of parenteral nutrition, the intestinal failure associated liver disease. When we mean balanced PN, we provide all the parenteral nutrition, provides the energy and amino acid solutions. We should avoid to give extra energy. The amino acid solutions should be age-adjusted with more rich in semi-essential amino acids as arginine, cysteine, taurine, proline, and tyrosine. So we have special dilutions, PN dilution of amino acids. The carbohydrate in the parenteral nutrition is glucose only and provides up to 70 to 75 of non-protein energy. And in the first days, as always in parenteral nutrition in children, we start with a smaller quantity in the solution, and then we increase to the final. The lipids in the parenteral nutrition are the source of the essential amino acids, essential amino acids, provide up to 30% of the non-protein energy, and they seem to have a special role in the pathogenesis of liver disease in the lipids, and especially the phytosterols of soya lipids that we mainly are used in parenteral nutrition products. So a few words about the main complication, which is a main determinant of the prognosis of these children. The intestinal failure associated liver disease. It seems that if we don't use the gut for enteral nutrition, this worsens the liver disease. These children mainly, as we said, most of the short bowel syndrome cases concern neonates. So we also, and premature neonates even more, with necrotizing enterocolitis. These are the vast majority of the representatives of the short bowel syndrome patients. So we have an immature liver that plays part in the liver disease. If we have recurrent sepsis or the first episode of sepsis is any lines, studies show that this is a main determinant of liver disease and, of course, bacterial overgrowth. As I said, the quantity and the quality of the lipids. So it seems that phytosterols from soya are main components in the pathogenesis of liver disease. How can we prevent? How can we prevent or protect the liver from the intestinal failure liver disease? We start as soon as possible the enteral feeding. We try to give a balanced macro and micronutrient IV supply, so the burden of the liver is less. It seems that cyclic PN, so not the whole 24 hours of the day, but intermittent PN seems to protect the liver from the liver disease. And it seems that children at home PN or under the intestinal adaptation team seems to be to have less liver disease. And a few things about the quality of the lipids. It seems that balanced omega-3 with omega-6 fish oils are protective, and high alpha-tocopherol levels in the PN also is protective. There's a lot of discussion about and a lot of studies using fish oil to prevent liver disease, but its use is not so clear, and it's not recommended. It is recommended in cases to treat the liver disease, so not for the prevention, but it is recommended for the treatment for a short period, because when we use fish oils, pure fish oils, we need to assess for essential fatty acid because fish oils lacks essential fatty acids, so we may have low essential fatty acids, and we need to, and that's why it's not recommended to use fish oils for long periods. So these fish oils emulsions are safe and useful to treat, and it's recommended to treat parenteral nutrition associated liver disease, and may be beneficial for long-term PM, but it's not recommended for use for prevention of liver disease. What is special about pediatric parenteral nutrition? It's really hard in these children, these small children, which each one is a different patient with a different part of remaining gut, to use ready-made lipid emulsion, parenteral nutrition emulsions and products. Even though they are cheaper, they are not suitable for small children. So the PN of these children should be tailor-made, adapted to the special requirements of each child. And of course, as these childs grow and as the adaptation process is taking place, these requirements are changing. So we need to monitor closely and change accordingly the parenteral nutrition that is provided. We should be very careful to prevent the common complication. So we need to use a strict aseptic procedure on the opening and the closure of a central venous catheter. It seems, as I said, that studies show that home parenteral nutrition, the children, if the caregiver is the mother or the relatives, they are more careful when they use the central venous catheter, and it seems from the studies that the complications are less than the children that are hospitalized. And of course, latest studies show that the team approach that enhances the better prognosis in these children. These are some photos where when the aseptic conditions, where the parenteral nutrition fluids are produced. And this is the special aseptic condition for the opening and closure of the central venous catheter. As I said, it seems that home parenteral nutrition is the best option for long-term PN. These children have a better quality of life, lower rate of central venous catheter infections, and lower costs because they are not hospitalized and the parents can go to work. Usually this, when the children are home PN, are on cyclic PN. So for home PN, stable patients on cyclic PN are required. The caregivers should undertake the training about handling the parenteral nutrition and the central venous catheter. And it should be available at 24 hours, 7 days a week, availability for approach to talk to the specialist, care nurse, and doctors. So for any emergency, they need to have direct access to the medical personnel. What is, except from the parenteral nutrition and the team approach, no, sorry, this is for the team approach. These are the SASs I mentioned before. It seems that the team approach, so a group of people as gastroenterologists, pediatric enterologists, nutritionists, special nurse, and biochemists that actually make the parenteral nutrition liquids. And also with a surgeon and a neonatologist, maybe, stoma nurse. All these people work, when all these people work together, it seems that we have a lot of better results and better prognosis in these children. So we see here that these are with white are before the multidisciplinary team's approach. The black layer is the early stages after children were taken in the intestinal rehabilitation programs, and this is the longer experience. So we see that they are free from total parenteral nutrition is increasing with the increased rehabilitation program approach, and on PN, and the decrease in deaths as children are incorporated in intestinal rehabilitation programs. The same here, we see that the survival of these children is significantly increased if they are under the care of a team. So in the same society paper I mentioned before, published in CPGN on 2017, the management of the intestinal failure by intestinal rehabilitation program is the current state of art, with limited but highly encouraging supported data on their medical efficacy. And as I said, the pediatric gastroenterologists, the nutritionists, the pharmacists, the specialist nurse are the main people in these teams, and also the psychologists, speech therapists, and psychotherapists are adding to this team, and of course, sometimes we need the surgeons. In this slide, we see a few medicines we use in children with short bowel syndrome. So sometimes, mainly in the initial phase, we may need to use drugs to slow the transit time, as loperamide. If we have ileal resection, we have extreme losses of bile acids, and we might have bile acid diarrhea to add to the watery diarrhea. So we might need to use cholestyramine. Sometimes somatostatin might lower the secretions of the gut, as we know, and so may minimize the diarrhea. But it seems that it plays a negative role in intestinal adaptation. So only in extremely rare cases we use somatostatin now. In the period immediately after the bowel resection, we have oversecretions of gastric fluids. So at this period, mainly in the first maybe 6 months, we use PPIs and E2 blockers to reduce the gastric fluids. And we might use the bacterial overgrowth. We might use a cyclic antibiotic for bacterial overgrowth to control bacterial overgrowth. And there is the study at the area of the stimulants of intestinal adaptation as growth hormone, insulin, glutamine, and pectin, and most of the study and with promising data comes from the studies of the GLP-2, a glucagon-like peptide 2 analog. So a few words about the glucagon-like peptide 2 analog. It seems that it increases villus height and crypt depth, so we have higher absorption, and tends to slow down gastric emptying and intestinal transit, so more time to absorb. And studies show that in short bowel syndrome patients, it facilitates weaning from PN. It is approved by the FDA and EMA for patients with intestinal failure due to short bowel syndrome. But however, there are some concerns. It seems that after stopping the provision of the glucagon-like peptide, then the effects are vanishing, and there are some concerns about the potential, because it is a growth factor, that it may cause hyperplastic or neoplastic changes. And of course, it's its price. It's expensive. It's an expensive therapy. As I said, in the team, the intestinal rehabilitation team, we also have the surgeon. Sometimes we might need them to deal with complications from the ostomies, but also they may help us for intestinal adaptation and lengthening. So in the recent years, we have some techniques that lead, surgical techniques that lead to bowel lengthening, mainly Bianchi and STEP procedures. And sometimes if we have a lot of diarrhea and high motility of the remaining intestine, we might use surgical techniques to diminish, to slower the transit and the motility of the intestine, as anti-peristaltic segment or surgical valves. We discovered for these techniques in these patients that remain PN dependent after a few years and have not managed to wean off PN. I said in a few years, because the time for adaptation is around 2 to 3 years in children. So after this period, we don't expect more adaptation, so enhanced absorption. So the condition is more or less stable. And if the children are still PN dependent, then we might use these lengthening surgical techniques. And there are some technical factors. So we need to have a part of dilated intestine more than 3 centimeters in diameter and length of intestine more than 20 centimeters or more than 40 centimeters of total bowel to use these techniques. This is the Bianchi procedure. As I said, we need to have a dilated intestine. It's more complicated, and it's a more complicated technique. And the other technique, the STEP technique, seems to be technically easier, and it's now the one that is preferred in these children. What is the role of intestinal transplantation in these children? Well, it is interesting that the prognosis after intestinal transplantation, the 5-year and 10-year prognosis is 50 and 30%. And when we leave these children on parenteral nutrition, the prognosis, the survival after 5 and 10 years is up to 85 and 75% respectively. So it seems that the parenteral nutrition is the only choice. There's a huge difference in the prognosis. So, and if these children are under the multidisciplinary programs, it seems that the survival is significantly improved. So the current recommendations for these regions is long-term parenteral nutrition as a treatment of choice for children with intestinal failure, including irreversible intestinal failure. Intestinal failure should be treated in centers with multidisciplinary teams and intestinal rehabilitation programs. And intestinal transplantation is reserved for irreversible intestinal failure with life-threatening complication as loss of venous access, severe, and end-stage liver disease. So that is the reason why we see how the number of intestinal transplantation patients have decreased during the last year, where the treatment with parenteral nutrition, long-time parenteral nutrition under the intestinal rehabilitation programs is taking place. So in conclusion, in these children with intestinal failure due to short bowel syndrome, we need to promote appropriate nutrition, to use enteral nutrition to maximal extent as tolerated, to use parenteral nutrition, but taking care to prevent complication. That is, as to use age adjust, so tailor-made parenteral nutrition, cyclic parenteral nutrition, and aseptic approach, and prefer, if it's long-term, home parenteral nutrition. We need to take home that we need to make everything to support intestinal adaptation, so enteral nutrition, use the gut as early as possible. Here, the role of some growth factors and intestinal hormones like glucan-glypeptides seem to have a beneficial effect on intestinal adaptation. And these alone or in combination with surgical techniques for intestinal lengthening. the treatment under the care of multidisciplinary intestinal rehabilitation teams and programs plays a significant role in the prognosis of these children, and intestinal transplantation in this patient is a choice only in special cases and not routine. Thank you.
Okay, many thanks, Dr. Dimakou, for this excellent presentation.